Good evening, everybody. My name is Luigi Natale from Catholic University in Rome, Italy, and it's my pleasure to moderate this webinar. This is the second webinar of 2025, organized by the European Society of Cardiovascular Radiology and is sponsored by Circle. It's my great pleasure to introduce this webinar. This is an advanced level or level 3 webinar and with a very hot topic that is the cardiac storage diseases. We have a very distinguished speaker this evening. As usual, two lectures. The first one will be held by Dr. Christos Gkizas from Lille, France, and the second one from Birgitta Velthuis from Utrecht, the Netherlands. Just for your information, you have a Q&A function in the screen, on the screen, and you can post your questions that will be answered at the end of the session, or you can use also the chat. So we can start briefly and with the first speaker, multimodality imaging of cardiac amyloidosis. Please, Christos, give your lecture.
Thank you, Professor Natale. Good evening to everyone. If it's okay with my screen, it's okay, visible for you. Thank you for all of you that you are connected today with us, and within approximately the next 20 minutes, we will speak for the role of imaging in cardiac amyloidosis. Yes. Well, an infiltrative systemic disease which is characterized by the accumulation of misfolded unstable proteins that are resistant to proteolysis. We know that cardiac amyloidosis has a multisystemic manifestations, can affect many organs, but still the cardiac amyloidosis has the biggest rate of mortality. Some years ago, we thought that late chain amyloidosis was the most frequent form of the disease with a very poor prognosis if left untreated. But with the advances, the improvements of multimodality imaging and the availability of different modalities, now we discover more and more cases of transthyretin amyloidosis, either acquired or hereditary, especially in elder people with this typical profile of dyspnea or cardiac failure with preserved ejection fraction. However, despite this increase of availability of expertise in different modalities, we see that the prognosis remains poor, and especially compared to the other types of amyloidosis like the polyneuropathy. And this is quite simple because the amyloid fibrils, when they begin to accumulate and infiltrate the extracellular space, they begin a circle that is vicious and never stops. It's a dynamic process when the rate of formation exceeds the rate of clearance. So there is a need to break this circle of deposition by changing this balance, and up to date, we have a lot of work to do. So whenever is the clinical aspect, the suspicion of amyloidosis, whether it's a dyspnea and arrhythmias, signs of cardiac insufficiency or polyneuropathy, the echocardiography is the exam, the first-line examination. It's available, it's not expensive, and it's very reliable. The strong suspicion of amyloidosis, of course, is said when we see this typical concentric remodeling of the left ventricle, this hypertrophy, which is also associated with the stiffness of the myocardium, and this classic strain pattern, this pattern of the apical sparing. Why? Because the amyloid fibrils develop from the base to the apex, from the endocardium to the epicardium. So the longitudinal fibers are affected very early, and the radial fibers stay in the mid wall until the late stage of the disease. However, the echocardiography has many limitations. It's important to remind that when we speak with this concept of heart failure of preserved ejection fraction, we surely underestimated many times the degree of systolic impairment. We should also remind that many times when a patient is referred for a PET scan, for a scintigraphy, for an MRI, with a suspicion of hypertrophy, there's no really hypertrophy. It's overestimated in the echo and is very dependent on the operator. We also, I would like also to remind that the apical sparing, this strain pattern is also, we can see also in other diseases like the aortic stenosis or other hypertrophic cardiomyopathies. And finally, which is also remind that the amyloid fibrils also love a lot the atrium. We have a significant, a very frequent atrial amyloid infiltration, which is responsible for the phenomenon that's called atrial electromechanical dissociation, a stiffness of the myocardium, which is very, very high risk of thrombus, even in anticoagulation, and even when this patient is in sinus rhythm. So the echo, it depends on the expertise of the imager. It has sometimes poor sensitivity. That's why the multimodality approach in cardiac amyloidosis is very important for the accuracy of diagnosis, for the prognosis, but also for the link of the imaging with the therapy, because it's important to improve the clinical impact in amyloidosis, and imaging has a central role. Of course, MRI is an exam of class 1, according to the consensus of experts of 2020, and that is mostly thanks to the big force of the MRI, the late gadolinium enhancement. The sequence 5 to 10 minutes after the injection of gadolinium that allows us to determine the phenotype of the majority of cardiomyopathies, this typical subendocardial circumferential enhancement in a non-coronary territory, with this classic pattern that follows the echo basal mid-ventricular with the relative preservation of the apex. You know also, of course, that in the Luke-Locker inversion time sequence, we have an abnormal myocardial annealing due to an infiltration of amyloid proteins. The myocard stays white, hypersignal, but this is a sequence that has low sensitivity, even when it's well applied from your radiographers, because when the infiltration of amyloids, it's very in the beginning, and we don't have a significant capillary regulation in the subendocardial space. We could have a normal myocardial annealing, and we can also find this abnormal finding in other diseases like the endomyocardial fibrosis or the hypertrophic cardiomyopathies. So it's a sequence with relatively low sensitivity. So the late gadolinium enhancement, we can say that makes the signature of the diagnosis, but it does not offer us up to now a real inherently quantitative information that we take from the parametric imaging. We know that in amyloidosis, the T1 values are increased in a significant way, and much more compared to the other hypertrophic cardiomyopathies. And we have still now many evidence from the literature that the T1 is more elevated in the light chain amyloidosis compared to the transthyretin form. So MRI offers us a diagnostic accuracy, there is no doubt, if we apply a good comprehensive protocol in our clinical routine and we use all these biomarkers, the concentric hypertrophy, the subendocardial enhancement with a potential transmural extension in more severe cases, the elevation of T1, and probably the association also of the thickening of valve and regurgitation, then we cannot miss the diagnosis. But an important question when we discuss for the MRI in amyloidosis, if it also can offer us precision. Because in this patient, for example, 67-year-old patient that he's followed for amyloidosis, he undergoes an MRI 3 years after his initial diagnosis. So we need to answer in a reliable way if the infiltration is stable or if it's evolved. From this image, we cannot clearly say if we have an increase in the infiltration of amyloids. So it's very important to have always in our reports, in our protocols, the extracellular volume. Why? Because the T1 mapping is a sequence that offers us is an inherent property of the myocardium, and it offers a mixed signal of the intracellular and the extracellular space. So if we want to separate these two and see what happens, we should inject the gadolinium and do the T1 post-gadolinium. In our department, we perform them almost 13 minutes after the injection of gadolinium in order to calculate the extracellular volume, which is typically increased, as you know, in cardiac amyloidosis with values that are important, more than 40%. So in this patient, what initially had an ECV that 45%, so with a moderate increase, the control is 65%, so we can say confidently that the infiltrations has really increased in this patient. The combination of T1 and ECV offers us a high diagnostic accuracy, and we know from the literature that ECV is independent, predicts independently the prognosis of the disease, and values, the cutoffs more than 58, 60% can predict the mortality in this disease. Lately, we add also in our reports another biomarker that includes all these, and we call it the myocyte volume response. Practically, it's something that we obtain from our LV mass and our extracellular volume, because when we calculate, for example, an extracellular volume on 55%, what remains, the 45%, is assumed to be the fraction occupied by the myocytes. So if we apply the LV mass multiplied with this remaining myocardial volume, we can approximately estimate the mass of viable myocytes, and is an interesting biomarker to add in our reports. Should we add also systematically the T2 mapping? Because if you noticed, I didn't put it in the protocol, the written protocol of diagnosis, and in your clinical daily routine, if you have an older patient that cannot hold very well his breath, and we need to shorten a little bit the protocols, maybe the T2 is not obligatory in the protocol. However, for the control of amyloidosis is a very interesting biomarker, and especially for the light chain amyloidosis. We know that the light chain fibrils have a toxic effect in the myocardium. So it's not surprising that when we control patients, even in chronic stages, the T2 is increased. And that could be a marker of the activity of the amyloid infiltration. And according to several studies, the T2 is predictive of prognosis just in light chain amyloidosis, even when it's adjusted for ECV and the proBNP. And I would like to remind, mostly for the younger radiologists that are connected with us, that edema can also be present without inflammation. So it's not surprising that in amyloidosis or the Fabry disease are the two hypertrophic cardiomyopathies that we see elevated T2 in the chronic stages. We have interesting perspective in this field with teams like the team of Bordeaux that tries to evaluate the role of fusion with new sequences, fusion of the T2 with the light gadolinium enhancement, and very soon we will have quite interesting results to see a mismatch, what it remains between the segments with edema and also the segments with late gadolinium enhancement, which are, of course, indicative of the amyloid infiltration. But MRI, despite all these interesting and reliable biomarkers, cannot answer the question quite often what is the histologic type of amyloidosis. And of course, the vast majority of cases, there are AL or TTRL amyloidosis, but still we have some other rare cases. You see, for example, 3 different cases of our department with this transmural typical late gadolinium enhancement. We can assume initially that we have an transthyretin amyloidosis due to this transmurality of the gadolinium. But these are 3 different patients, and the first patient has a apolipoprotein amyloidosis, which is a rare form that we discover more and more thanks to this multimodality approach. The apolipoprotein amyloidosis is often associated with a renal involvement and is a type of the disease that loves the right ventricle. So even when we see a transthyretin-like pattern in the MRI, when the RV is a little more thickened, we have a tricuspid valve dysfunction, we have a late gadolinium enhancement of the right ventricle and atrium, in a more disproportional way, we should always think and note the suspicion of apolipoprotein amyloidosis. This is another case of apolipoprotein amyloidosis, which is detected with phorbetamin PET CT. And if you see, we have just uptake only in the left ventricles and not in the right ventricle. So it's another even more atypical case to illustrate us the multimodality approach, and very often, even if we add 2 or 3 modalities, we cannot take the answer very, very easily. So the diagnostic algorithm, the pathway to see our specific diagnosis is not always very easy. When we have a plasma cell dyscrasia, so a suspicion of AL amyloidosis, the CMR is an exam of first line that we should do urgently after the echo. If we have the suspicion of transthyretin amyloidosis, then when we have uptake of the radio tracer 2 or 3 according to the Perugini classification, the pathway is really established. The scintigraphy remains the gold standard thanks to its great specificity, and we don't have serious problems. However, when the uptake is 0 or 1, we should have also a control for possible light chain amyloidosis. And then if also the monoclonal protein is normal, is negative, what we should do? We should request for MRI, or we should review probably images of MRI that have already been realized. So deep learning studies and artificial intelligence studies work a lot on this very interesting and demanding domain. If they could help us in order to filter patients and to orientate patients, especially after the first step, when we have the first symptom of amyloidosis, when we have the echocardiography, to see in which modality we should send the patient. And also we have very interesting studies in the second step, when we are not certain if which type of amyloidosis we deal with, to review previous CMR cases. There is an interesting and very, very recent study of the team of the Calgary and Toronto University, when researchers tried to evaluate and to see with 3D phenomics if they could discriminate the amyloidosis from the other hypertrophic cardiomyopathies. And they did that just only exploring the TDU cine imaging data, and with excellent accuracy of 90%. In the same orientation, and as we lived in the crazy period of photon counting CT, and some people characterize it as a new modality, we could say that also photon counting CT, thanks to its excellent spectral information, could probably detect also new cases of amyloidosis thanks to the late iodine enhancement. Here is a typical case of a sarcoma hypertrophic cardiomyopathy, but you see the excellent correlation of the scanner with the late gadolinium enhancement, but amyloidosis, it's not this type of the disease. The interstitial expansion, it's much more different. So we work a lot in this field to see also if the late gadolinium enhancement could also have a great correlation in the photon counting CT in cases like amyloidosis. But we can also reliably obtain the extracellular volume thanks to the photon counting CT and thanks to the late iodine acquisition only 5 minutes after the cardiac CT. We have already very interesting data in the literature, and we see that the estimation difference between CT and MRI is only 2 or 3%, so we can apply the extracellular volume to probably detect new asymptomatic patients. Finally, concerning the photon counting CT, many researchers have also tried to evaluate the role of a strain of GLS added also to the extracellular volume. This team of Zurich has very recently published an interesting paper that combined the GLS with extracellular volume in patients that underwent a scanner before TAVI, and they achieved to detect new cases of amyloidosis that were not previously known, because the echocardiography and the assumed that the dyspnea and the clinical symptoms were due mostly to the aortic stenosis and not to the amyloidosis. And we should remind in this point that almost 15 or 20% of patients with aortic stenosis, they have also translated in amyloidosis according to the literature. And if patients have both stenosis and amyloidosis, the cardiovascular mortality risk, it's much more, it's very increased compared to patients that have just only one, just the aortic stenosis. So we discuss all of this advanced progression and in improvements in the artificial intelligence, in new modalities, in new sequences, because not to highlight the role of multimodality imaging in the diagnosis or the prognosis of the disease, because it's important to have a link of the imaging with the therapy. It's important to see how the multimodality imaging approach can have a real impact in the new treatments. Concerning the light chain amyloidosis, we know that already from the literature that MRI has an important prognostic role. I'm sure that most of you have already read this excellent paper of Martinez Najaro that showed practically that the MRI 6 months after the initiation of chemotherapy predicted mortality before the pro-BNP and other clinical biological markers. We have also quite interesting data concerning the role of strain in the light chain amyloidosis in a quite big series of patients of the same group of research. The baseline GLS and the GLS after the improvement of GLS after the chemotherapy was independently associated with a reduced risk of mortality. And the GLS is also extensively studied in the anselamimab, the new monoclonic antibody that removes amyloid deposits in AL amyloidosis. Whether you have suspicion of amyloidosis or another hypertrophic cardiomyopathy, it's always interesting to apply the biventricular strain in your reports, because we know now from the literature and different reviews that the strain adds significantly, increases significantly the prognostic role of reports, of MRI reports. Concerning the light chain amyloidosis, we have also very interesting new studies concerning the florbetaben, a radio tracer that is shown to be quite interesting in the detection of light chain amyloidosis. And now we have some studies that will get out in the literature concerning also the treatment response. Finally, concerning the trust-threatening amyloidosis, here we are in a more difficult, in a more complex crossroad, but also very interesting, and mostly since 2029. The stabilizers and the gene modulating therapies that are approved, they reduce the formation of amyloid fibrils, but they not accelerate the removal. The gold standard of therapy remains until now tafamidis. There are more treatments that have taken approval, or they maybe take approval within the next months, like vutrisiran, and we wait very impatiently the results of CardioTransform trial that checks the efficacy of hypertension in a huge cohort of patients, 1,400. It is the first study that includes MRI results in extended way in a large cohort of patients. I'd like to finish this presentation, and I insist in this point because I would like to remind that tafamidis is given in patients, in symptomatic patients of amyloidosis, but we see in literature and clinicians see in the everyday clinical routine that even asymptomatic patients with uptake 2 or 3 in the scintigraphy have significantly increased possibility of cardiovascular mortality compared to asymptomatic patients with uptake 1. And that highlights the importance to treat also asymptomatic patients and control all these patients with multimodality imaging, and especially with MRI, thanks to all these biomarkers that can provide to us. It's important to scan more and more asymptomatic patients, just only patients that have been already in treatment, and why I would like to show you 3 patients that have been published in the New England Journal of Medicine in 2023. Probably many of you have shown this cases report. 3 patients with typical symptoms, a diagnosis of trust-threatening amyloidosis. These patients, 3 years after the initial diagnosis, with no treatment, with no stabilizers, with no modifying treatment, they presented significantly a decrease of the aspect of amyloidosis that was confirmed with MRI, the histology, and also the scintigraphy. That illustrates that probably in the future, the antibody-based therapies is the key for the treatment in amyloidosis. And I would like to repeat that we should scan more and more patients in the beginning of the disease when they are asymptomatic before their treatment. So I would like to finish my presentation. It was a really difficult challenge for me to include in approximately 20 minutes the different roles and importance of different modalities in cardiac amyloidosis, but we know that amyloidosis is a multimodality imaging disease, a multiparametric imaging disease. All the radiologists should include in their report systematically all the biomarkers that we discussed in the presentation. But the most important in the future is how all these different modalities can link, can connect the images with the treatments in order to approach more and more in the histology of the disease. And the new improvements in technology and artificial intelligence are paving the way for these improvements. Thank you for your attention.
Thank you very much, Christos. Excellent presentation. Thank you deeply from my heart. You said that it was difficult in 20 minutes, but you did it. Thank you again. Of course, as I told you at the beginning, the question and answer session will be at the end of the presentations, both of them. So it's my pleasure to introduce now the next speaker without any need for presentation, Birgitta Velthuis from Utrecht, Netherlands. She will speak about hereditary disease with HCM phenotypes. Please, Birgitta.
Okay. So hopefully everybody can see my presentation and hear me. I am at home. So it was a difficult period of time. And the coming 20 minutes, I want to talk to you about hereditary diseases with a hypertrophic phenotype. My disclosures are that I do have a working collaboration with Philips. And these are the learning objectives. So, okay. To learn about the spectrum of hereditary diseases with a hypertrophic phenotype, to recognize the features and to understand which MRI parameters will help you differentiate hypertrophic cardiomyopathy from other causes like storage diseases. So this is the teaser case that I submitted of hereditary diseases with hypertrophic phenotypes. And these I will discuss in the coming 15 minutes, and we will give you the results at the end. So I think all of you know, because this has been discussed previously, also at the ECR meeting, the 2023 ESC guidelines for the management of cardiomyopathies, that now we look at the non-ischemic cardiomyopathies, it is a phenotype-based approach. And what we have is new is the non-dilated LV cardiomyopathy has come in and the non-compaction cardiomyopathy has gone out. In all of these cardiomyopathies, we do need to look for a genetic basis for the etiology by family screening and genetic testing to integrate the genotype into a phenotype etiology. So first and foremost, if we look at hypertrophic cardiomyopathy, it has the highest prevalence of the cardiomyopathies, 1 in 500. And in the guidelines, we're looking at hypertrophy that is at or above 50 millimeters. Even though if we do have families with known genetic cardiomyopathies, we will consider above 30 millimeters to be abnormal. So we have pathogenic gene variants in about 50%, with more than 50 gene variants, enormous amount, but most of them are sarcomeric gene mutations and most are the MYH7 and the MYBPC3. So that makes it a little bit easier for us. It is usually an autosomal dominant inheritance, although men do have more expression and often a more severe expression than women. If we look at the comparison between sarcomeric mutations versus no mutations, the sarcomeric mutation often present earlier with more severe hypertrophic cardiomyopathy and late gadolinium enhancement and have a higher prevalence of family history and sudden cardiac death. First and foremost, we must say that having a gene mutation doesn't mean you will develop that hypertrophic cardiomyopathy. So you need to follow up family members who have the gene mutation. So one example, I have shown this previously in talks. This is an 18-year-old woman who had an out-of-hospital cardiac arrest in the gym. She had a blank history. She obviously has a very asymmetric hypertrophy with a wall thickness of 35 millimeters. There is extension into the right ventricle, so they have RV involvement, and she has more than 15% late gadolinium enhancement. Her twin sister, of course, was also imaged, and we found the similar asymmetric hypertrophy, late enhancement, and both turned out to have that sarcomeric MYBPC3 gene mutation. So another case of a 14-year-old girl who came to our hospital because they suspected of an RV tumor on echocardiography, and there was also uptake on the FDG PET. But what we see is that there is a septal hypertrophy of 42 millimeters extending into the RV apex. And she again turns out to have a sarcomeric MYBPC3 gene mutation. And you see in this 14-year-old that there is already extensive late gadolinium enhancement. And I've seen her 10 years later, and she has only slight progression of a hypertrophic cardiomyopathy and still does not have an ICD because there's no arrhythmias have been connected to it yet. So we do screen the family. So her mother turns out to have a mild basal anteroseptal left ventricular hypertrophy, only 40 millimeters, but because she's family member of somebody with a sarcomeric gene mutation, we said this is abnormal. We have very minimal late gadolinium enhancement. So she was tested and turned out also to be a carrier of this MYBPC3 gene mutation. So you see that in one family, you can have very different expression of your hypertrophic cardiomyopathy. And then this was one of our latest cases. It was a 21-year-old male footballer who, I'm not quite sure, but he went to his general practitioner, nothing to do with any cardiac complaints, but the general practitioner did put the stethoscope on his chest and heard a murmur. And this sort of started the ball going, and he turned out to have a septal hypertrophy, so an asymmetric hypertrophy, 42 millimeters, again, extending into the right ventricle. And with athletes, we should not be seeing a wall thickness above 12 millimeters, certainly not in female athletes, not in male white athletes, and we can see it up to 50 millimeters in black elite male athletes, but certainly not in the 42 millimeter range we're seeing now. And this one turns out to have a sarcomeric MYH7 gene mutation. This is the other common gene mutation. So if we look at the differences in the sarcomeric genes, these are the thick filaments. We most often will have that MYH7 and the MYBPC3, and the MYL2 and 3 are very rare. So you will not see that much. And there'll be no significant differences in the phenotype between these two major sarcomeric gene mutations, not in LGE presence or burden, not on the mass, and not in your left atrial dilatation. If we compare the thick to the thin filaments, so thin filaments more in the titans, we'll see in the thick filaments, so in our MYH7 and MYBPC3, we'll have higher ejection fractions in the normal range. They'll have more often, will have LVOT obstruction and more often a family history of sudden cardiac death. But they will not have significant differences in late gadolinium enhancement or the degree of left ventricular hypertrophy. So to summarize, for the sarcomeric hypertrophic cardiomyopathies will be your most common genetic hypertrophy. You're looking for an asymmetric hypertrophy. You're looking for patchy late gadolinium enhancement in those areas of hypertrophy. So not at a far location, but in the areas of hypertrophy, and look for LV or LVOT obstruction, SAM, apical hypertrophy with an aneurysm, and RV involvement. And again, we should, according to the guidelines, now starting to be measuring the late gadolinium enhancement, because above 15% is a marker, a prognostic marker for arrhythmias. If we now move on to the non-sarcomeric hypertrophic cardiomyopathies, these are much less common, only about 5 to 10%, and we have various causes that I will briefly discuss. So looking at this, one study looked at 1,731 non-related hypertrophic patients and did genetic testing, and only found 1.5% gene variance, and very little in the Fabry, the familial amyloidosis, the PRKAG2, and one patient with a Noonan. So although it's very rare, if you don't find in your gene panel a common cause, you should be testing it. In the Netherlands, we do cover most of those in our gene panel, and you should be doing family screening, because some of the patients do come into, can be a sort of approach for enzyme replacement therapy to give them a better prognosis. So first of all, the inborn errors of metabolism, the storage diseases like the Anderson-Fabry, the Pompe, the Danon, and the AMP kinase. The inheritance is often autosomal recessive. Some are X-linked and will give you very good patterns. So if we look first at the Anderson-Fabry, it's an X-linked lysosomal storage disease in the GLA gene. And this GLA gene, its aim is to break down lipids and fat to prevent accumulation of sphingolipids. So if it's not working well, you will get an intracellular accumulation of these glycosphingolipids in a lot of tissues. And because it is in many tissues, you will get diverse symptoms of cardiac symptoms, renal symptoms, peripheral neuropathy, and cardiovascular events. The classic onset is quite early, especially in men, but you do have an atypical onset, late onset, especially in women. Why should we be finding these and identifying them? Because timely treatment will stabilize symptoms and slow progression. It's not curative, but you need to identify this early and not at an end stage, because then the treatment will not help. So the classic findings on cardiac MRI, I'm sure most of you or all of you know that, is a concentric hypertrophy and fibrosis, usually in the mid-wall on the basal midventricular lateral wall. So that is what you're looking for. If you find that, a concentric hypertrophy, you start thinking, okay, this could be a Fabry. This is in the differential, but it can be a lot of other things. And what helps you is you will have low native T1 values. even in the mild left ventricular hypertrophy. So it does help you for that early diagnosis. And as you see, low values can be a Fabry, but it can also be in iron deposition. The atypical presentation, not very often, but sometimes we see an asymmetric hypertrophy, even an apical hypertrophy or LVOT obstruction. So we must realize that it's not always concentric, and a quarter of the patients do not have late gadolinium enhancement. And to identify them again, you need that T1 mapping. Of course, iron storage disease, more in the southern parts of Europe, we don't see that much, usually more often from blood transfusions in the Netherlands than thalassemia, but we seldom see them in an advanced stage that we have hypertrophic cardiomyopathy. But you can find a hypertrophic cardiomyopathy, and usually we'll have the T2 star mapping. But again, the native T1 is very sensitive because it will give you low values. So we will be doing both. The question is, we have a protocol for heart and liver. We will also be doing the T2 star and the native T1. The more rare causes, like Danon disease, is a LAMP2G mutation. It is more a glycogen lysosomal storage disease. It is associated with cardiomyopathies, myopathies, so you can try a biopsy. Ocular albinism, so you will have like retina pigmentation defects, and at times mild intellectual disability. It is X-linked, so this might dilute the effect in women who have a double X chromosome. So males usually have symptoms at a younger age with more muscle weakness, and females may present later with either hypertrophic cardiomyopathy or dilated cardiomyopathy, and this can be without myopathy. There is not a specific treatment at present, but there are clinical trials underway with gene therapy. This is one example, a 20-year-old woman with left ventricular hypertrophy, supraventricular arrhythmias. She did have that retinal pigment loss, and she did not have a myopathy. What we see is, again, that quite characteristic pattern of a concentric hypertrophy with extensive, widespread late gadolinium enhancement. So this is not your normal sarcomeric mutation. If we look at the next one, the PRKG2 mutation, which is a very rare autosomal dominant non-lysosomal glycogen storage disorder, the prevalence is up to 1%, but usually less, and it often presents in late adolescence, but sometimes, as in this case, it can present later. So what you will often find is a left ventricular hypertrophy that can progress to dilating cardiomyopathy when you go into more cardiac failure. It will give you conduction system abnormalities that will often require a pacemaker in midlife, and it can also give you myopathy. Again here, similar to the other storage diseases, you expect a concentric hypertrophy and extensive late gadolinium enhancement. And this is an example of a late presentation, a 74-year-old man who came in who had atrial fibrillation and muscle weakness and turned out to have a reasonably mild concentric left ventricular hypertrophy, but that strange extensive LGE pattern, and the genetic testing showed this gene mutation. The other case we have is a 46-year-old woman who only was imaged because her 25-year-old daughter had a sudden cardiac death, and on autopsy they found a dilating cardiomyopathy caused by this mutation. And her mother, turns out to have a mild hypertrophy, but again, extensive late gadolinium enhancement in a strange pattern, but not a diffuse pattern like you would see in the amyloid. One thing she also had, so she did have elevated T1 and ECV, you would expect that with the fibrosis, but she also showed some myocardial edema on the T2 fat set, shown here in the middle images, and again, on the same places where you do see some late enhancement. So you can see that in the previous talk, we said that you can also see that in amyloid. We can see that in a lot of cardiomyopathies. Because of the T2 fat set, she did have an F2G PET because we were wondering, can't this then be some strange sarcoidosis or something? And that was negative. If we look at neuromuscular diseases, usually we're looking at the muscle dystrophies and we'll have a dilating cardiomyopathy. And hypertrophic cardiomyopathy is rare. very rare, with the exception of Friedreich's ataxia, which is primarily a neurodegenerative disorder, but it does have multisystemic effects that can include hypertrophic cardiomyopathy. We must realize that we will already have identified these patients because of cardiomyopathy as the presenting disorder in only 5%. But finding that is important because cardiac dysfunction is the cause in up to 59% of the deaths. Again, here, usually a mild concentric hypertrophy and very limited late gadolinium enhancement, usually in that lateral wall. So again, the lateral wall, you're thinking about Fabry. It's a place where you're going to see myocarditis. Of course, you can have sarcoidosis. So again, here, you are looking at that, and you will use your T1 mapping to rule out Fabry or iron deposition. Mitochondrial diseases have different causes and various phenotypes, hypertrophic cardiomyopathy, but certainly also dilating cardiomyopathy and various inheritance patterns. One important one is the matrilineal inheritance line, where only women can pass on the gene mutation. Usually, your standard cardiomyopathy gene panel will not include mitochondrial gene sequencing, so you might miss this on the initial cardiomyopathy gene panel. And why is it important? Because a mitochondrial dysfunction can be a modifier in sarcomeric hypertrophic cardiomyopathy, so like a second hit, making it worse. And it can be the primary driver in a genotype negative hypertrophic cardiomyopathy. So initially testing negative, but then turning out to have mitochondrial dysfunction. And again, it's important because you do have some possibilities for mitochondria-targeted treatment. So this is a 27-year-old female who originally was genotype negative in her standard cardiomyopathy panel, done a few years ago. But years later, in our hospital, she had additional testing that did reveal a pathogenic variation, the MT-T1 gene, so mitochondrial gene mutation. She has a concentric hypertrophy, and she has a very extensive, patchy, diffuse late gadolinium enhancement. Again, you're seeing a lot of areas that have a normal myocardial suppression that are normal. So this is not amyloid. That would be very strange in a 27-year-old. But you do have an extensive, diffuse, patchy late enhancement. And this is, I found another article about this, that you do see this left ventricle with extensive LGE, and it also gives then LV dilatation and a decrease in ejection fraction, and that same pattern that you can see focal areas of high T2, as seen here in the yellow box. So these are three siblings who all had the same gene as our patient, and you can see that late gadolinium enhancement is very similar to our patient, patchy and diffuse. A very, very rare one is the malformation syndromes. And the most common mutations are in genes that code for proteins of the RAS mitogen activating protein kinase. And this pathway is used to transfer signals from the extracellular region to the nucleus, where the genes are activated for cell growth and differentiation. So you can understand if this pathway doesn't work, you might get abnormal cell growth and abnormal differentiation. Examples are the Noonan, Leopard, and Costello. Will you be seeing this? Probably not. Most are diagnosed already in childhood and also followed with echocardiography. But we do have milder forms, especially of the Noonan, that are diagnosed later. So you might come across it. And this is one case of a man with mental retardation. He has a hypertrophic cardiomyopathy already known since his teens, and he died at 37 years because of his ventricle arrhythmias. He has a septum thickness of 30 millimeters, a very high LV mass, a normal ejection fraction, very slight late gadolinium enhancement, so not that extensive pattern, and really normal T1 and ECV values. Amyloidosis we've talked about, so I don't really need to go into that, except again here, you should be doing your T1 mapping because next to that next to the diffuse LGE, you're looking for very high T1 values to separate it from hypertrophic cardiomyopathy or from a Fabry. And then the last two are the endocrine disorders. So we do see left ventricular hypertrophy in mothers with diabetes, but it is transient, so the babies will have that. And it has been reported in patients with acromegaly and pheochromocytoma. Again, you will get a resolution of the left ventricular hypertrophy with treatment. And last, the drugs that can cause, of course, the anabolic androgenic steroids that are still not uncommon in male strength athletes, and a very rare side effect in certain drugs. Here again, the left ventricular hypertrophy will not very seldom be above 50 millimeters, even in the athletes with steroids, and potentially it is reversible. So the learning objective first was to learn about the spectrum of hereditary disease. I would recommend you to read this article. It does give you the full spectrum, and I hope I've shown you good examples from that. This is the teaser case. Of course, the first one is a very asymmetric, the LGE in the hypertrophy. This is sarcomeric hypertrophy. The second one with the focal LGE in the lateral walls of Fabry. We have the Danon, and we have that mitochondrial hypertrophic cardiomyopathy with that diffuse late enhancement. So to recognize the features, those cases show that sarcomeric will be more asymmetric hypertrophy, more patchy LGE, but in the area of hypertrophy. So you shouldn't be seeing that really a lot in other areas with a normal wall thickness. Look for that RV involvement and left ventricular outflow obstruction. The non-sarcomeric will more often be concentric and will show very various late Gadamer patterns, but you should be using your T1. And the non-mutation hypertrophic left ventricular hypertrophy will be more concentric, but also usually less extensive hypertrophy and less extensive LGE. And in that last objective, to understand which MR parameters, of course, your cine imaging to look at the pattern of the hypertrophy. Is it asymmetric? Is it concentric? Is it involving the right ventricle? Late Gadamer enhancement, focal LGE in the hypertrophy, think sarcomeric. Diffuse with high T1 mapping, think amyloidosis. Focal LGE lateral with low T1s, think Fabry. And that diffuse patchy will either be storage diseases or mitochondrial. Of course, you always have to consider sarcoidosis in the background. And thank you very much.
Thank you very much, Birgitta. Wonderful lecture. Every time I hear from you about hereditary cardiomyopathy, I learn something. So thank you so much. We are very close to the end of the session. I have time for one question coming from the audience. For the first speaker, the question is, where do you measure ECV in amyloid? Mid-septum or zones with highest native T1 values?
Thank you for the question. We do both. For the when we do when there is a suspicion of amyloidosis, we do the polar map with all the segments as we do the post-treatment with circle, but we provide also the measure of the mid-ventricular. We do both.
Okay, thanks, Christos. And my very short comment from Birgitta concerning the approach to cardiomyopathies. I suppose, as for example in my hospital, you rely very much on a multidisciplinary approach and a teamwork for these diseases, isn't it?
Definitely. So we have a wide protocol. We always have the T1 mapping in it, and we do have our meetings with the cardiologist, but also our multidisciplinary meetings with our geneticists, and we discuss all the cases that turn out to be negative, but also the ones that are positive and have strange mutations. So that does help to learn more about the rarer cases.
Thank you very much, Birgitta. If there are no further questions from the audience, I thank you both speakers for the wonderful lectures we heard. And for those who are very late in putting on some questions, our speakers will be available to answer offline to a couple that appeared right now, but it's time to close the session. Thank you again very much to the attendants and to the speakers, and to Circle for sponsoring the webinars. Good evening.
Thank you. Good evening.